All right, so I just wanted to say welcome again to everybody. Thank you for coming on to our educational series. My name is Laura Giusto. I am one of the female pelvic health specialists at Chesapeake Urology. And tonight we'll be going over, how we approach urinary tract infections and our diagnosis and treatment. We'll be going through some epidemiology, some definitions of different types of urinary tract infections, how to diagnose and how to treat. Some things to consider. I'm mainly focused on women, on female pelvic health. We will have to revisit UTIs in men, as well as some neurogenic bladder UTIs, people who are catheter or suprapubic tube dependent in the near future. So we'll take care of that on an upcoming series. And so why do we care about urinary tract infections? Well, we know it's the most common bacterial infection that exists. It's also the most common hospital-acquired bacterial infection. And it's one of the most reasons why urologists see patients. More than 10 million physician visits a year and more than $3.5 billion spent yearly. And what about women and UTIs? So 60% of women will experience a symptomatic acute bacterial cystitis in their lifetime. So 3 out of 5 women. And then 20 to 40% of them are likely to experience an additional episode. And of that subset, 25 to 50% of them will go in this spiral, recurrent episodes, recurrent UTIs, and be coming to your office. I just need to minimize everybody for a second. And why is this important to us? Well, everybody on this call is the gatekeeper. Sometimes people don't get excited about recurrent UTIs. It's a lot of talking, but I think we should see it as an opportunity it's a chance to educate patients. It's a chance to empower them. And it's a chance to teach them about how they could prevent themselves and how they could put away some of the misinformation. So going forward, we prevent things like overuse of antibiotics. The overuse of antibiotics today is really leading to something called collateral damage. And so everybody who sees a recurrent UTI or a UTI consultation on a virtual visit or in the office is a gatekeeper. You could practice antibiotic stewardship. And so this is why sort of the merging or hybrid of the talk is really to go over some of the information, the education, the literature, the guidelines, and then the talk tracks so that the patients get it. And so that's the takeaways from today. So I briefly mentioned collateral damage. This is basically when injury is inflicted on something other than the intended target. For instance, when I was, in the infancy of my training, we handed out fluoroquinolones like crazy. You were getting, a stone procedure. We just sent you home with a 5 or 7 day course. I mean, we were not practicing a lot of our AUA best practice or guidelines for peri-procedural antibiotic prophylaxis at that time. In the meantime, we were probably causing, drug-resistant organisms to be bred and proliferate. And so by really being stewards of antibiotics, we could help prevent collateral damage. I don't have a slide, but if anybody knows Ann Cameron, she's amazing. She really harps and speaks about this on multiple levels, but we have not had any antibiotics truly developed in the last 2 to 3 decades. 1, maybe 2 emerging right now. And so as drug resistance increases and we don't have anything novel or new on the line, we're really putting ourselves in a tough spot and painting ourselves into the corner. So that's why we sort of have to take it seriously with how we dole out antibiotics. And it's hard because we are, I think, people pleasers, many of us, and patients come in and they demand antibiotics or they think that's what's right and that's what they need to get better. And so these are our opportunities to take the time, sit down and talk to them about how they could be treated. So first, when we talk about definitions, a urinary tract infection is technically greater than 100,000 colony-forming units per milliliter of bacteria, and it's taken from a midstream urine culture. Now, what's interesting about this is the true definition, this is what we will live up to, but sometimes your urine culture is a snapshot, anecdotally, sometimes, it was less than 10,000 K, but, in a day or two, it might have brewed out to a little bit more. So there is a little bit of wiggle room there on the side, but the true definition is greater than 100 K. Additionally, cystitis is different from a urinary tract infection. So cystitis is a clinical syndrome. It's basically, burning with urination, frequency, urgency, suprapubic pain, but in the absence of a true infection. So it could be from interstitial cystitis, levator spasm, other etiologies than actual infection. And lastly, there's the idea of asymptomatic bacteriuria. So this is really encountered in the elderly population and patients with neurogenic bladder. Patients are not presenting with symptoms of urgency, frequency, pain, suprapubic pressure or pain. But sometimes we screen everybody who comes into our office just to move things along. So if little old lady comes into the clinic and we tested her urine and send the culture anyway because she had some things in her urine dip, and something grows in the culture, and we call her up and we're like, the antibiotics are coming to you, she's going to say, I don't know what you're talking about. Why did you send a urine culture? I'm not symptomatic. So I think we need to be very careful and know that actually 1 out of 10 people will have bacteria in their urine if you tested everybody on this call. Urine is not technically sterile. It's part of our sort of microbiome. It just exists. And as long as that bacteria that's just chilling out in the bladder is not penetrating and causing injury to the bladder lining, it's not a true infection. So it does not require an antibiotic treatment. So what's the best way to test for a UTI? Well, we all utilize urine dips. Urine dips are little sheets of paper. We get the sample in the cup and we just dunk the paper in, let it dry, either run it through a machine or compare it to the bottle. And so urine dip is about 60 to 90% sensitive and specific for urinary tract infection, but it's really there to give a presumptive diagnosis. So what are the things we're looking for on a urine dip? The things we usually look at are blood. There's many reasons why people can have blood on a dip. And again, this is just a dipstick. So it talks about trace hemolyzed, small, medium, large. It's really not quantitative at all when we compare it to our microscopic hematuria guidelines and everything. But people can have low estrogen state, tissue and have some excoriation of their vaginal tissue as they void. They may have stones. There's many reasons to have blood in the urine. So it's not always indicative of a urinary tract infection. A dip will also pick up leukocyte esterase, which this is a substance that's released from white blood cells. So again, white blood cells aren't necessarily hand-in-hand specific for UTI. Any kind of inflammatory process can release white blood cells and therefore leukoesterase. And patients have stones, they're passing a stone, and it's kind of eliciting a inflammatory reaction. There's going to be plenty of leukes in the urine. So last thing that we often look at is nitrate positive. So everybody has urinary nitrates. We eat them, they get to the urine, and bacteria can convert nitrate to nitrite. And so often, if somebody is nitrate positive, it could be indicative of certain types of bacteria in the urine that do this conversion, such as E. coli, Klebsiella, Enterobacter, Proteus, and some staph. However, some bacteria do not convert nitrate to nitrite, and those are your Pseudomonas, your Streptococcus, Enterococci, Candida, and again, the caveat, some staph. Some staph does, some staph doesn't. We should also take into note, if patients coming in for a UTI, we need to ask them, did you take azo or proteum or anything before you came in? If you see an orange urine sample and it's positive for nitrates, that can falsely make a nitrite on a stick positive. And so we need to ask that in our history and rule that out. Also, if the dip strips have been sticking around for a while, they're old or have been exposed to air for a while, you could also get a false positive. So technically, after sort of a dip, if you had a suspicious dip, maybe there's some lukes, there's some nitrite or blood, the best thing would be to look at a urine sample under the microscope for a true urinalysis under a high-powered field. And if we saw bacteria or a certain concentration of white blood cells in that high-powered field, we'd be more presumptive that the patient had a UTI. But a lot of our offices don't have microscopes. If yours does, though, that's a great tool to utilize. But the best way to test for a UTI is urine culture. We also can't exclude physical exam. There are gross anatomical abnormalities or sources that we pick up on exam, anything from your vaginal wall masses, which might give up, a diverticulum. And many things we might see on, a cystocele coming all the way out with lots of stagnant urine. So there's not enough to be said about that physical exam. So next, we're thinking about diagnosis. Maybe there's a positive UA, we have a culture pending. We have to determine, is our patient an uncomplicated patient or a complicated patient? And so the kind of standard uncomplicated UTI in a female is a healthy female that has structurally and functionally normal urinary tract. So what does that mean? Well, let's look at the complicated. The complicated patient, of course, any male that has a UTI is quote unquote complicated. But then structural abnormalities might be the presence of vesicoureteral reflux. If somebody has bladder outlet obstruction, so they had a high PVR when they came in, they have stones, they have neurogenic bladder, if they've had any kind of pelvic floor surgery in the past, slings, things like that, they all make the patient more complicated. That is not a functionally normal urinary tract. So that's what separates uncomplicated from complicated UTI patients. I'm going to briefly kind of fly through the pathophysiology of UTIs and get more to the meat of what you guys need, which is how do we treat them. So I'm going to make this brief, but the information is all here. Most importantly is that there are steps that go into somebody getting a UTI. Bacteria getting from tissue to the urethra and into the bladder, and then getting into the cells to cause an insult to the lining of the bladder to therefore cause an infection. So first you need adherence, which is bacteria sticking to the tissue of the genitourinary tract, and then it sort of migrating and internalizing into cell layers. We know that certain bacteria do this better, adhere and descend and internalize into cells better than anything else. So these are uropathogenic E. coli's, which is really 3/4 of most of our community-acquired UTIs. But the other ones that are most common are Klebsiella, Enterococcus, Group B strep, Proteus, and Staph. And so these are sort of virulence or bacterial factors that make things more common to adhere and to get into the urinary tract. Many different types of E. coli and bacteria have pili. I call them basically claws, things that help the bacteria hold onto your urothelial cells so they're not washed off easily with urinary stream or exfoliation or things like that. But in the same way, patients might have urothelial cells that are easier for bacteria to bind to them. And so that's just genetics. My mom always got UTIs, I always get UTIs kind of thing is what you'll hear. And that might just be because the urothelial cells of that patient make them more predisposed to bacteria binding to them. So there are other things that make bacteria bind to the vagina better. And so we're talking about female pelvic health here. And the idea is that the vagina is meant to, keep things out. There's labia, there's hair, there's discharge. There are sort of processes in place to try to prevent things from ascending and getting into the vagina or the urothelium. Things that make it easier for bacteria to adhere to this area when people have leakage of stool, when women are using condoms with spermicidal agents on it, and you're killing the natural flora of the vaginal floor, so the bad bacteria from the gut can live in the vagina. And then when people are using intermittent or indwelling catheters, there's creation of biofilms and a disruption of the microbiome of the pelvic floor. There's other things too, and I think I'll get into it a little here. First, for young women, these E. coli and uropathogens tend to really stick more to women over 65 years old versus premenopausal women. But they did notice that bacteria can adhere in higher phases in the early phase of the menstrual cycle. Additionally, women can do things like waxing and causing microtrauma to the tissue. Because the hair is supposed to be a preventative way to get bacteria from, getting into the to the urethra and up into the bladder. So if you have a woman who's, waxing normally and keeps getting UTI, they're taking away one of their barriers from preventing UTIs. Additionally, postmenopausal women, when they have low estrogen state, we'll get into that in a moment, but the labia changes forms. Usually there's involution of the labia minora. Instead of being tight and closed, sort of you see these just open introital, the labia go to the side, and then there's less hair down there because they're in the hypogonadal state. So all those things are reasons why later on in life women will get urinary tract infections. So besides bacteria adhering, it also has to get into the tissue. We know that different virulence factors in these bacteria make them more likely to invade and get through the layers of the urothelium. This also sort of contributes to this idea of intracellular colonies, or the other term is intracellular or intrabladder colonies or intrabladder communities. So oftentimes what we'll see is, there's an infection that affects the lining of the bladder wall, but sometimes that bacteria internalizes, it gets under some of the layers of the bladder lining and causes an eruption of an infection down the road once some of the linings of the bladder have shed off, just like your skin sheds and new layers appear. And so some of these bacteria are worse than others. I briefly talked about some of the natural defenses. The bacteria that exist naturally on the pelvic floor are supposed to be there to prevent other bad bacteria from the GI system and elsewhere from overtaking and overpowering them. And this is mainly lactobacillus. There's urine characteristics that prevent you from getting a urinary tract infection, mainly alkaline urine. So acidic urine tends to promote UTIs, so alkaline urine is a more healthy way to prevent UTIs. Vitamin C is one of the things that helps with that. You need to have an intact immune system. People who have diabetes or immunocompromised, we know, are more prone to UTIs, and sort of how the tissue exfoliates and gets rid of things and has barriers. We talked about hair. And estrogen state also helps as a natural defense. So what's the most important thing? We talked about diagnosing a UTI, urine dip, urine culture, and then when you're trying to, treat, what are our antibiotic selections for an acute urinary tract infection? Well, I try to go through the same things before I treat someone. First, I'll check their allergies. And this is something that you often have to actually ask the patient. It's really hard for you guys when you come in and you see somebody who's allergic to fluoroquinolones and Bactrim and macrobid, and then their culture has a few different resistances, and you're throwing your hands up in the air and trying to, get an infectious disease doc on speed dial. But the truth is, most people don't have true allergies. They may have some sensitivities. For instance, that one caused some stomach upset, or I got some diarrhea from this bacteria, or I'm sorry, this antibiotic. And so teasing that out is really important, because you need to give people tools back to put in their toolbox, so you don't run out of options and rely on PICC lines and IVs, and most of us don't have that time. And so what I would prompt you to do is find an allergist near you, give them a call, let them know you're going to start sending them patients to figure out and take that time to go through sensitivities versus true allergies. The other thing you have to be wary of is just other medications. Luckily, our EMRs prompt us on a lot of these things to say, you're putting in this medication, it has an interaction with this psych med. You know, but also Bactrim and warfarin is an issue. So being able to, you know, skim over their medications yourself before allowing the EMR to prompt you if there's an interaction, I think is warranted. And then basically what I do is work down a list of antibiotics that I deem sort of safer to a little bit more aggressive in terms of the side effects. And so my first line and a lot of the guideline first lines for antibiotic selection in an uncomplicated UTI is listed here. Macrobid is more bacteriostatic than Cytal, so it's actually a 5-day course and not a 3-day course, so you take that twice a day for 5 days. Bactrim and Keflex can both be offered in a 3-day course. There are other medications listed here, you know, if somebody has sensitivities to cephalosporin, which has less of a side effect profile, so that's worth noting. And then for an uncomplicated UTI, we kind of leave ciprofloxacin and fosfomycin here. Now, fosfomycin is kind of an asterisk. It's a medication that has been around for a while. It's used in Europe all the time. It just isn't used commonly in the United States because it's actually not covered by a lot of the insurances. So it actually works great without a big side effect profile, but it's often expensive. So when I try to prescribe it, sometimes it's $120 for a patient to pick up 1 or 2 of these 3-gram packets. But if somebody did have an uncomplicated UTI and they had all these allergies, and fosfomycin was my only shot, I'd just tell them it might cost a little bit. We've really shied away from using ciprofloxacin for uncomplicated UTIs. Like I said earlier, we used to use it all the time. We like it in urology because it has such great bioavailability. You could sort of swallow a pill in the office, it's getting to the bladder quickly and penetrating most of the genitourinary tract for any manipulation or things we do, and that's why it's so great for UTIs. But the side effects and black box warning has been sort of heralded recently, and so we're kind of putting it to the bottom of the list if we really have to lean on it. For the complicated UTI, this is for women, not men, because we treat that a little bit different. But I'd like to say this is sort of my practice, not so much guideline based, but I try to avoid the macrobid for the complicated UTI. You might even get these cultures that say it's macrobid sensitive, but I do find that it's more bactericidal, static. So even doing a longer course of it doesn't knock out some of these multi-drug resistant bugs. Instead, try the Bactrim and the Keflex for longer courses. You can lean on the Cipro then. And the fosfomycin, which is, again, a 3-gram packet, you mix it in some fluid and drink it all down. This is when I extend it. So I'll say every 3 days, and I'll either prescribe 2 or 3 packets, depending on the patient and their scenario. So I wanted to go through briefly some of these antibiotics. So we know cephalosporins by generation. We have a few different options here. You know, I think a lot of our docs like cefuroxime. But as you go from a 1st generation to a 4th generation drug, the gram-positive coverage decreases. But this is important for your tools when you're trying to look at old cultures and figure out what they might need. In terms of Bactrim, you know, this inhibits bacterial folate metabolism. I like the medication because there's less risk for C. diff. It does cover strep staph and most gram-negative rods, but it really doesn't treat Pseudomonas. And again, you have to look out for your patients who are on warfarin. You don't want to give them Bactrim if they're taking warfarin. Macrobid is another one of our, like I said, first-line meds, especially for uncomplicated UTIs. We really like this because it's excreted into the urine primarily, and 30 to 40% of the med is unchanged. So less of this medication is going to like the gut flora and is instead staying where you intend it to be used. So when people get diarrhea or sometimes gas or, a lot of gut changes from their antibiotics, macrobid is a little bit more gentle when it comes to that. It does cover E. coli and enterococci, some of our two most common UTI causing bugs, but it doesn't cover the Proteus, the Pseudomonas, or the Serratia. This was the phosphomycin packets. And this is really good too, because 40% of it, just like the macrobid, is excreted into the urine, almost 100% unchanged. And like I said, we really actually think this is a great drug. That's why it was put into our recent recurrent UTI guidelines, because it has broad spectrum against multi-drug resistant E. coli and enterococcus. It's just we need our insurance companies to catch up to us and give us coverage. Our fluoroquinolones are our Cipro and our levofloxacin, and they cover most gram-negative rods, which is often what we find in the bladders. GI bugs ascend into the urothelial tract and cause infection, and that has good coverage. And as you heard me say, a lot of these other medications didn't cover Pseudomonas well, but fluoroquinolones do. So when you start getting more complicated UTIs, we can lean on the fluoroquinolones. It's just that the black box warning has gone on it recently. We have associated tender rupture and a lower seizure threshold, especially in psych medications. I just threw aminoglycosides in here. Many people will use an IM injection of gentamicin in the office. And that's also because it covers most gram-negative rods. So that's also leaned on for maybe not so much urinary tract infections, but office use to prevent a UTI at time of procedure when patients can't tolerate other oral agents. So I'm going to breeze through this a little bit too. There's some different slang and colloquialisms and things that come up when we talk about urinary tract infections, whether it's unresolved, whether somebody had a persistence, whether it's actually recurrent. So an unresolved UTI is really a UTI, an infection that doesn't go away when the antimicrobial course ceases. And so why does that happen? Well, one, if you empirically treated the patient, you gave them antibiotics before their culture came back, and the bacteria might have been resistant to it. Second, and this only happens 5% of the time, but it does happen, bacteria can develop resistance to an appropriately chosen antibiotic. So this is, survival of the fittest. Some of the bacteria that was infecting did have some genes that protected them from whatever antibiotic that the majority of the bacteria would have been killed by, and then they could prevail and predominate through the bladder and then cause a unresolved UTI. Often there's a second resistant pathogen, and it's kind of selected out. So you kill the number one bug that grew out on the culture, and this other sort of neighbor was happy. Now there's all this free territory, and they move in and grow and proliferate and take over. There's rapid reinfection. If you had a source connecting to the bladder, people have colovesical fistulas. You may have knocked out what was there, but the bacteria has, a slide or a rapid highway right back into the bladder. And so the UTI really never goes away. And sometimes based on kidney function and other things, you can't concentrate the antibiotic in the urine. Other reasons, there's sinitis, like a kidney stone, and the bacteria just cling to it, and a little short course of bacteria won't resolve the bacteria that's on anitis. So one talking point we should go over is this idea of antibiotic resistance. It's real. It's things as gatekeepers, I think, and as antibiotic stewards really need to be accountable for and take the time to go figure out. Every area, every region of the country has different antibiotic resistant, profiles. Right now, we know in the United States, we have E. coli has nearly a 30% resistant rate to fluoroquinolones. And that's just because of our practices over the last 2 decades. It's all we used. So the E. coli that lives in survival of the fittest, can take on a fluoroquinolone no problem nowadays. But how that affects to you and your practice is what hospital you're in has a profile that is known. What the community, what the people that come into that hospital, what the resistant profiles are for the bacteria that's showing up for them. And so that's an antibiogram. And so if you have time, if you're, in a hospital or, in the greater Baltimore area, you could get these, and it can help change your practice. So this is just an example of one where for this hospital, you could say for, say, E. coli in this area, for cefazolin, for Levaquin, for Bactrim, they were less favored. There was higher resistant rates. And so if you were trying to treat a patient, you would go after the meds we knew were more common to kill the E. coli in your area. So I really do prompt you all to sort of inquire at your hospital, talk to the ID team. I'm sure they have these on hand, and try to get it for yourself, and it will help your patients. Bacterial persistence. This is the reemergence of an identical bacterial strain from a site within the urinary tract after it's, a UTI has been treated and you've actually shown a negative culture. This is typically because something exists in the urinary tract, upper or lower, that keeps bacteria on it, and we could almost always identify this on CAT scan or cystoscopy. So what are some of these causes of bacterial persistence? Infected stones, chronic bacterial prostatitis, when people have either atrophic kidneys or these duplicated systems, or one of them's obstructed and there's stagnant urine that keeps making people get infected. Foreign bodies, in our world, that's slings and sutures from other previous pelvic surgeries, and urethral diverticulums, and so on and so forth. So I touched on this in the beginning, but in terms of asymptomatic bacteriuria, again, this is why everybody needs to correlate. Do they have symptoms with the presence of bacteria in the urine? Because if we found people who had bacteria in the urine and treated them versus people who had bacteria in the urine and didn't treat them, and they were all asymptomatic, there's ultimately no decrease in morbidity or mortality for the patients who went untreated. However, for asymptomatic bacteriuria, there's two populations we usually treat, and that's pregnant women and those about to undergo a urological procedure. A few other definitions just thrown out there. We'll get into more detail in some of our other talks, but a CAUTI, a catheter-associated UTI, this is more in the context of a recent hospitalization, a Foley catheter was put in. And so it's really defined by a catheter that's been in for greater than 2 days. A urine culture has 2 or less organisms that are greater than 1,000 coliform units, and you have to have at least one symptom. So there needs to be a fever. The patient has to have suprapubic pressure and pain. Maybe they have flank pain. This whole idea of urinary urgency, frequency, dysuria doesn't make much sense because they have a catheter in, but maybe they're leaking around the catheter. This is because of biofilms and other things, and we're really only treating, again, if symptomatic, if one of these symptoms of UTI is present with the positive culture. People can have yeast in their urine too. This is tough because sometimes it is colonization, and so we need to find out again if somebody is symptomatic, yes or no. And the thing that we will often treat them with is when it's lower urinary tract is fluconazole, and we usually treat them with an upfront loading dose of 2 pills followed by like a week's worth of 1 fluconazole a day. However, when people have infected stones and it's more the upper urinary tract, then they're, and I know in my area where I trained in Philadelphia, it was a 30% resistance rate for fluconazole. So if somebody had a fungal ball or we had yeast growing and they were going to have a procedure, we just started them on micafungin until we could speciate and find out resistant patterns, just because fungal cultures take longer to grow back. Sometimes they're 5 days. And so that's something that's sort of an asterisk to pay attention to. I threw in these slides just because, again, as gatekeepers, you guys might see this. It's one of those things I always had to look up, but urinary tract infections during pregnancy, these are complicated by definition. And 1 in 5 women are going to get a UTI during pregnancy. there's a lot of screening that's done, and they're typically or often asymptomatic. But there's a high risk that these can develop into pyelonephritis or infection of the kidney. So every pregnant woman has a urine dip when they come in for their OBGYN screenings. And it puts them at risk if it goes untreated for premature rupture of membranes, preterm labor, etc. You know, if a woman, like we said, has slightly increased risk from asymptomatic bacteria becoming pyelonephritis, this is because there's stagnant urine, there's some hydra on the right side associated with pregnancy. And so this really puts the mom at risk for septic shock, respiratory and renal failure. So this is why we screen for it and pay attention to it. I'm jumping ahead real quickly. If somebody has 1 episode of pyelo or 2 urinary tract infection, they'll often get suppressive antibiotics. And if somebody did have that episode, the 2 to 4% had pyelonephritis, they get hospitalized, they get IV antibiotics. If they're really not improving, that's when you get imaging. Sometimes there's stasis of urine up in the kidney because of that hydro of pregnancy. Sometimes there's a stone. And so what are your pregnancy antibiotic choices? Everything on the left are things that are safe: penicillin, cephalosporins, macrobid, and fosfomycin. Really got to avoid the fluoroquinolones, trimethoprim, erythromycin, and tetracycline. So now we're getting into the meat of it. This is really where it's at. This is what you're going to see, and you're going to see all the time. And again, let's look at recurrent UTIs as an opportunity to empower and educate patients. And once they know how to treat things and you give them the tools, it may take 3 or 4 or 5 months to get them on the path, but then they stop coming back and they're happy and they appreciate all the care. So really a recurrent UTI is defined as 2 or more culture-proven urinary tract infections of acute bacterial cystitis and associated symptoms. So they need to have symptoms with each event, and 2 in 6 months or 3 or more times in a year. So why? Why does this happen? So this is a graph of symptomatic cystitis in women, and we know that these infections increase with age. And typically the 2 peaks, we have some old terms that don't really make sense anymore, but it used to be called honeymoon cystitis. So early on in school-age girls, there wasn't a ton of urinary tract infections. And then the idea of honeymoon cystitis is once women got married and started having intercourse, there was introduction of bowel bacteria closer to the urethra and getting and sending urinary tract infections. Well, most women, or many women, don't wait to get married to have sex nowadays. And so we shouldn't call it honeymoon cystitis, but it's the same idea. This sort of 18 to 24 year age, there's just a boom in young women getting urinary tract infections. Then it just continues to rise. And most of our elderly patients will be more prone to urinary tract infections as they become postmenopausal. So what are the risk factors for recurrent UTIs? Being menopausal, diabetes, things that make you immunosuppressed, you know, the genes, if you have those urothelial cells, which make it more prone for bacteria to bind to them, personal behaviors, and your anatomy, if you've had previous pelvic surgeries, prolapse, things like that. So what's the relations, this is starting with our younger women and then moving up and on, UTIs and intercourse. So anytime, you know, you have disruption of the vaginal flora and introduction of bacteria from, you know, one end of the body closer to the other end of the body, it makes it easier for bacteria to get into the urethra. Additionally, people use things like diaphragms, maybe not so much anymore, but diaphragms, which are basically foreign bodies and can colonize bad bacteria. Spermicide use, which again kills the good bacteria of the vaginal floor, and the introduction of a new partner, which they have their own flora and bacteria on them and can introduce that during intercourse. And then the later on in life group is really just because of low estrogen state. So normally the vagina is, has a low pH, and as with the low estrogen state, as time goes on, the pH goes up, and then the good bacterial lactobacillus acidophilus cannot live there anymore because the vagina becomes basic. That good acidophilus can't live there anymore. And so your protective layer and flora is gone. We talked about less hair. We talked about thin, less robust tissues. Glycogen levels are decreasing. And so basically colonization of the vagina with bad bacteria occurs. Add on to it other things like, because you're low estrogen state, you have some weaker pelvic floor muscles, you have some weaker collagen and some weaker support tissues. You're going to have prolapse. If you have prolapse, you don't empty as well. Now you have elevated post-void residuals, and you're holding on to urine, which is stagnant and can let bacteria grow faster. So all these things have some kind of associations with recurrent UTIs just due to the low estrogen state. Diabetic patients, patients with diabetes, all are more predisposed. There's diabetic cystopathy, the nerves start to go, and then the bladder can't empty and there's stagnant urine in the bladder. And then there's glucose getting into the bladder in people who are poorly controlled, and which is just, food for bacteria. We talked a little bit about genetic susceptibility. There's a positive female family history with a relative rate, which is very significant. So don't discredit. Just when patients get very frustrated, they're young, this keeps on happening, and you ask them and they say it went in the family. That's fine, we know it, but now we're gonna give them tools on how to prevent it. Some things to sort of throw out the window that don't exist anymore, and these are hard habits to break. I think a lot of people believe in this and do it, but tampons and even douching don't cause urinary tract infections. Whether you wipe front to back or back to front, whatever's easy, that actually doesn't cause recurrent UTIs. Getting in a hot tub doesn't. Everybody says wear cotton underwear, but it doesn't even matter. There's no association that we found in our literature between all these things. And so luckily, 2 years ago, we came out with recurrent UTI guidelines. This is really giving us a leg to stand on with our antibacterial stewardship. So I'm going to briefly go through this. It's broken down into sort of how you go about your history and physical exam, and then how you offer antibiotic treatment or prophylaxis. And so when you do the history and physical exam for somebody coming into your office for recurrent UTIs, you need to confirm the prior UTI diagnoses. Remember, they can't just say, oh, I thought I had symptoms and I went to a patient first and they sent, or whatever your urgent clinic is, and they dipped me and gave me antibiotics. That's not a true urine culture with bacteria growing out. So, we need to define that. Say, did you actually have 2 or 3 urine culture proven infections, and were they also symptomatic at the time? On the visit, you want to obtain any urinalysis, and then you're going to send a urine culture and sensitivity. And it's really important to perform a pelvic exam. We miss a lot of these things, diverticulums, anterior vaginal wall masses, reasons why there's incomplete bladder emptying, a urethral carbuncle, a cystocele, things like that, that if we recognize it, then we're not just throwing antibiotics at the patient, we're treating the structural abnormality. And then once that's fixed and they empty better, there's a chance that we fix them without, years worth of antibiotics. So perform the pelvic exam. Then you also have to be on the lookout for complicating factors. So what are complicating factors? Again, any anatomical or functional abnormality of the urinary tract. If a patient is immunocompromised, or, if there's multi-drug resistant bacteria. So this is why your history is really important. This is why looking at past medical history and seeing they're diabetic, by seeing there's glucose in the urine dip, by seeing, what type of medications there are. There's certain type of diabetic medications that actually promote glucose in the urine. So those are things you might have a discussion with the endocrinologist with if you can't come with any other sources. But if people have had slings, if people have, multiple other stone procedures, they might have stones, they might have a ureteral stricture. There's a lot of reasons that complicating factors can exist, and it's usually a skim of the, past medical and surgical history, and look at the medications. And so if somebody has complicating factors, you may lean on some upper tract imaging, a cystoscopy, urodynamics, but the guidelines do say basically you don't need, in the standard index patient in a healthy young woman or a healthy woman, you do not need imaging to work up a recurrent UTI. And this is what's going to be hard for you guys as gatekeepers, is you're going to have people referring to you. You're going to have patients saying, I waited to get and see the urologist, and you're doing nothing. You're not looking in my bladder. You're not getting me this ultrasound. Well, if their history does not offer complicating factors, it is your job to educate and reassure. And sometimes that's the hard thing. But the rate of UTI with a diagnostic cystoscopy is 5%. So 1 in 20 people is going to get a UTI if you're looking in their bladder. In an index patient, you could cysto a whole lot more than that, and you're never going to pick up anything. So you're actually putting patients in danger by giving them more UTIs by doing unneeded diagnostics. Again, in the history, what may make them more common, more likely to have a complicating factor by history. You might want to look for any risk factors from fistulas. And then reasons to do cystoscopy, which we said not to do before, but if anybody says they have hesitancy, they have to push to get urine out, if they have a sensation of incomplete bladder emptying, so those are obstructive complaints, that might egg you on to maybe, does this patient need a cysto? If they've had a previous surgery, if anybody has had a bladder neck suspension or a sling, and they have recurrent UTIs, I cysto them because I want to make sure they don't have a urethral or a bladder perforation of that mesh as a nidus, and I see it often. And then indications for maybe some either ultrasound or CAT scan. If they've had recurrent pyelo, if they might have stones that might be obstructing, if they have unexplained bleeding, or stones or fistulas, those are all reasons that maybe you need to find out source, the connections, and get imaging there. So what are sort of the take-homes from the H&P from the guidelines? Complete your H&P with pelvic exam. They have to be culture-proven symptomatic UTIs to make the diagnosis, greater than 2 in 6 months or 3 in a year. Positive cultures cannot be contaminated. A mixed urogenital growth does not count. And if you have a patient, and I would say this is, more than 50% of our elderly population cannot give a good mid-stream culture, that might be a good opportunity to say, you know what, you're coming in, you think you have recurrent UTIs, we keep getting mixed urogenital growth. I don't think you're squatting well. Maybe you walk down with a walker. How are you going to hold a cup and squat at the same time to get this sample? Let's just cath you. Let's just minimize this chance of contamination. Put a straight catheter in a sterile way, and get the best chance to diagnose you the first shot. Also try hard not to treat low colony counts. Try to stick with the greater than 100K. I know I said earlier, sometimes it's a snapshot, and if you repeated a culture in a day or two, it would be greater than 100K. But we've had a lot of studies that show that actually drinking plenty of water is a way to sort of wash out, dilute the system, and get bacteria out before it gets more invasive. Again, if a patient's asymptomatic, don't make a practice to be checking and sending urine cultures on asymptomatic dips. Patients are colonized, they don't have sterile urine, and they should be taught to say, when you have an infection, what are your symptoms? All right, let me know when you're symptomatic. Otherwise, we're not taking care of the urine. So if there's no complicating factors in your patient that you came in, did an H&P, did a UA, sent out the urine culture, and have diagnosed them with recurrent UTIs, now's our time for shared decision-making for how to treat. And so we break this down into one, just antibiotic treatment, and later we'll talk about prophylaxis. So first we start with episodic therapy. So this is just, I know you got 3 or 2 in the last 6 to 12 months. How are we going to treat this one in front of us? And so the selection of meds is based on everything we talked about earlier, use of first-line therapy, the shortest course available, find out your antibiogram for your area, and treat them that way. you know, if they have resistance, this is where we might have to extrapolate and use the IV drugs. And besides that, allergist having an infectious disease doc or something else sort of on speed dial is for these few patients. Then there's this whole idea of self-start therapy. So what is self-start therapy? Well, it's offered to compliant, reliable patients. I don't know if you have many of those, but if you recognize one and they're with it and they understand your conversations and, you know, they're not just saying, you know, I have a UTI because I had a dip that was positive, then you're going to have culture data. And based on their previous culture data, you're going to say, you know what, I see that these bacteria existed, they were sensitive to these antibiotics. Going forward, if you have very specific symptoms with your UTI, you always get frequency, burning, sometimes blood in your urine, or the suprapubic pain, and it takes, you know, 2-3 days to get into the office, and by then it's a rip-roaring UTI, you could give those patients self-start antibiotics. Antibiotics they already have at home that they start taking at the very start of their treatment or their symptoms. And so this is my practice. I will look at their culture data. I will pick an antibiotic that has been sensitive in the past, and I'll often dispense 30 pills. I'll say, you know, if you're sexually active, take 1 tab, you know, within an hour or two of sex. And at the very start of your UTI symptoms, you could take your 3 or 5 day course, depending on what the medication is. If it's Macrobid, it's going to be a 5-day course. If it's Bactrim or a Keflex, I'll tell them it's a 3-day course. Something that's really important here to communicate, and you'll see often in recurrent UTIs, the infection is treated, but patients are symptomatic thereafter. I see it very commonly with our young women, and they need reassurance. They should continue with things like Proteum or Azo to soothe the bladder lining, drinking plenty of water. I actually encourage Tylenol. You know, there are some studies that ibuprofen minimizes pain, but when we were studying interstitial cystitis, we learned what insults to the bladder lining. Anti-inflammatories actually prevent the healing of the bladder lining that's needed with interstitial cystitis. You know, irritation. And so I've extrapolated that to urinary tract infections. And so I just encourage Tylenol instead of ibuprofen. If you give sort of more penicillin or cephalosporin-based medications, women might be more prone to yeast infections too. So you might want to offer some self-start of fluconazole. So fluconazole to prevent a yeast infection. I'll usually say, you know, take 150 milligram tab at the completion of your antibiotic course, and if you're still symptomatic, take a second 3 days later. And you're just trying to minimize calls back to you. So you gave them the self-start antibiotics, you might want to consider the self-start fluconazole. So the guideline highlights to our treatment pathway: avoid collateral damage, try not to treat without a urine culture. So collect that urine culture, send them home with Proteum, cranberry extract, fluids, and wait for the results to come back. If they're miserable, you could treat them empirically, but then please follow up. Tell them to stop their course if it comes back and it's negative, or switch your antibiotic right away so we don't develop resistance. And then again, treat it based on the culture in our first line, second line, uncomplicated, complicated fashion. Next is prophylaxis. And so this is an idea, nobody really likes the prophylaxis, but sometimes the UTIs just don't go away despite prolonging courses, despite having the correct antibiotic. This is this idea of what I'd call intrabladder colonies or communities that I kind of mentioned with pathophysiology and internalization earlier, and this theory that some very virulent bacteria, they can penetrate the layers of the bladder lining. They exist in pockets, so they're not actively infecting the surface lining of the bladder, but as those layers shed and they sort of pop out into the bladder and then can reseed and reinfect, patients can get just this whirlwind spiral of infections. And so sometimes a low dose antibiotic nightly for an extended course may help as those layers of the bladder shed and let those bacteria pop into the bladder and into the urine from sort of reinfecting the bladder lining. because your low-dose antibiotic is keeping the urine, bactericidal or like as an antiseptic, and is preventing the bacteria from reinfecting the lining. So a lot of our studies are based on 6 to 12 month data. And you really want to pick things that have minimal effect on the bowel flora. So that includes trimethoprim, which is one of the two components of Bactrim. And this is great for people who have self-allergies. A low dose, so we often prescribe Bactrim double strength, but a very low dose Bactrim, a low dose macrobid, and a low dose Keflex. So I'll tell you, I know studies say 6 to 12 months, the guidelines say you could go that high. I usually do a 2 to 3 month run. So for Keflex, it might be 125 milligrams. Trimethoprim, it might be 100 milligrams, and macrobid, or often cheaper mecrodantin, it's 50 milligrams. And I just do it nightly, and I do it for 2 to 3 months. And if I do say 2 months, I'll have the patient come and follow up me at 3 months. So they have like a month off the prophylaxis, and we could capture them, see how they're doing. They're doing okay. Great. High five. Hopefully you've been doing some other things since you've been gone over those 2 to 3 months, which we'll talk about in a second, which is optimizing the tissues to minimize the chance for recurrent UTI. For macrobid, if you're going to use it long term, know that if a patient starts coughing or something, there's this micro chance of pulmonary fibrosis from long-term use of macrobid. So you just want to, ask them if they got a chronic cough and maybe check a chest x-ray. And so we're really winding down now. And so how can you help prevent recurrent UTIs? Because, you're a hero if you treat one, but you're a bigger hero if you prevent them from coming back. So this is something I'll send out to all of you guys. This is sort of a summary of everything I talk to a patient about, of reasons for why, or things they could do to potentially prevent recurrent UTIs. This talk track, can take a lot of your time. You talk about sort of being postmenopausal, how their tissue down there is not healthy anymore because the pH has changed, because it's not stimulated by estrogen anymore. Now bad bacteria move in. And then if somebody is, a candidate for vaginal estrogen cream, you actually had to then find the vaginal estrogen cream that their insurance covers and teach them how to use it. So that's part of your conversation. If you start talking about things, all my little things on this list, that's a big conversation. They're going to forget a lot of it. So I have the short sheet, and then based on whether it's a young patient, a postmenopausal patient, they have a lot of complicating factors, I will personalize this. I'll check some of these things off. I'll write some things on the ledgers, and I'll give it to them so they remember what we discussed. So these are all things that might help UTIs long term. Again, estrogenation of the vagina. When it's a low estrogen state, it becomes basic, that bad bacteria moves in. By taking a pea-sized amount of vagina, putting it on the fingertip, doing a fingertip application. So I tell people, you don't need to shove it up there with an applicator. I throw that out if I give them a sample. It's just a pea-sized amount to the entrance of the vagina on the anterior wall, just enough to get it off your finger, 2 to 3 nights a week. It's going to do everything you need to optimize the tissue down there. Increases blood supply, increases vascularity, lubrication, robustness of tissue, improves the pH, allowing good bacteria to move back. We also have to manage expectations. This isn't used for an acute UTI, it's a prevention plan. And so it may take 2 to 3 months for this medication to actually improve the health of the pelvic floor. I also compare it and use an analogy like going to the gym. So you could go to the gym and get a membership for free for 2-3 months and go get buff and lean and really feel great about yourself. And then if you stop going, your body's just going to go back to whatever it was right before you started. Same thing with vaginal estrogen cream. If you could get them to buy in, this is a lifelong, practice. If you use it for a little while, it's going to help for a little while, but if you stop using it, it's not helpful anymore. So you got to keep it up. I'll talk a little bit about D-mannose in a second. That's a naturally occurring sugar. It comes in tablet, capsule, and powder form. We have good studies that show 2,000 milligrams of it daily helps bind up E. coli in your gut, so it prevents E. coli from adhering and then ascending to your urethra. In terms of antibiotics, we can empower people that are reliable with postcoital or self-start antibiotics. Probiotics, I leave on there. There's mixed literature. There's literature that's good. There's literature that's not good. I like the theory of it. You're trying to recolonize the pelvic floor with good bacteria to prevent bad bacteria from colonizing the vagina and the area around the urethra. There are oral and intravaginal options, but I'll slide through that. The jury is still out. Cranberry extract, this is huge. Everybody comes in talking about all the cranberry juice that they're drinking. Our studies, the studies that exist, show that 36 milligrams of PAX, proanthocyanidins, is the concentration of cranberry extract needed to get down into the urine to prevent E. coli binding to urothelial cells. So you'd have to drink a huge amount of cranberry juice and just basically flood your system with sugar. And that can be a lot for patients, you know, to try to even get that concentration. So tell them to lay off the juice. And if they are going to get a cranberry extract, what we recommend is a medication that actually has that designated concentration. There are a few that exist. We offer Theracran, you know, at Chesapeake Urology. Allura is available on Amazon. And I have a lot of patients who have done some research and found other options, but I tell them to look for that concentration. There was a study that showed that, you know, women over a year, if they had UTI-like symptoms, the ones that were taught to drink 2 to 3 liters of water a day versus the ones who drank less than 1.5 liters a day, if they looked at their UTIs over the course of the years, the one who were drinking a lot of water, they had like 3-fold a decrease in UTIs compared to the ones who drank less than 1.5 liters. So that's a tough one. Drinking water really does flush out bacteria, but it also makes people pee all the time. So it's checks and balances, or the lesser evil there. People who have problems emptying, you're going to want to encourage timed voiding. You want to get the stagnant urine out, and they might not sense that their bladder is full, so it's telling them to look at the clock and peeing every 2 to 3 hours, and double voiding would be a way to get that urine out and minimize the chance of urinary tract infections. When it comes to sex, just make sure patients aren't using spermicides. Postcoital voiding is on here, but I'm pretty sure the literature is mixed about that. Everybody does it anyway. But if they're a postcoital antibiotic patient, encourage them to do that. And so I've got a lot of data here that goes over the vaginal estrogen replacement and how this is, by the way, women getting vaginal estrogen when they're postmenopausal is our #1 way to prevent urinary tract infections over and over again. So if you could take the time on your visits to really, again, explain to them why it's important, explain them the 2 minutes about the physiology about it and why their ongoing efforts are preventative, they're going to buy in. So this is really important. I could also send out to you guys, there's papers, there's group statements, and there's paper that basically say estrogen is not a risk factor for, you know, breast cancer, if, you know, uterine cancer, DVTs, all these things. We have all these patients who grew up in a time period where they had flip-flopping ideas about hormonal replacement therapy, getting hormones by mouth, or getting patches, and having high systemic values of estrogen circulating by this replacement therapy. I say this is not bad. This is like a facial moisturizer. When you put moisturizer on your face, you're treating your face. You're not treating your thumb or your elbow, right? Same idea with the vaginal tissue. By putting a pea-sized amount of vaginal or a pea-sized amount of estrogen cream on the vagina, you're just treating that area. People have looked at blood, you know, estrogen levels. In the first 2 to 3 weeks, there maybe were some increases in some absorption of estrogen right after starting estrogen therapy. But then as the tissue became more robust, that dropped off. And there's nearly no systemic absorption of estrogen from that vaginal therapy. And even if there was, I say it's a drop in the bucket to what used to be going through your system. So we know it's safe. Patients who have had DVTs, patients who have had breast cancer and uterine cancer and ovarian cancer, we have a lot of literature that says this is safe. You shouldn't be scared of it. Sometimes patients need some reassurance, so you could say, that's fine, you had breast cancer 15 years ago or 5 years ago. Why don't we get you to sort of talk to your oncologist and make sure they feel comfortable with that? But I confidently tell patients it's okay. We talked about prophylaxis after intercourse. Really, like I said before, the data on probiotics is mixed. I like the idea though. I get the theory behind it. There are compounding pharmacies that put probiotics, specifically lactobacillus, into some of these creams that have estradiol in them. And then you have probiotic as well. So if they're doing a dab will do you to the vagina 2 to 3 nights a week, and there's some probiotic in there. Why not? You know, I don't think it's hurting. And then additionally, I tell patients, go when it's buy one, get one at the pharmacy and just stock up. We did talk briefly about proanthocyanidins, aka PACs, and then how they block things from binding. And really, it's not the cranberry juice, it's this extract that's important, and they need to get that certain concentration. Methanamine salts, aka Hiprix, is also something that's in your back pocket. I use this rarely, but sometimes you just need to add something else. Some get a patient out of their spiral over the hump, you know. So basically it hydrolyzes ammonia to formaldehyde and makes the urine bacteria static. There really are a few side effects, and that's why it's offered. But the pills are big, and sometimes it's expensive for patients. So I don't find they stay on it long term, or they often, you know, fall off on their own. There are some future directions in Europe, and we have some studies about some emerging vaccines that might be offered. I don't think this is going to be our fix. I think it's other versions of prevention. But in conclusion, you know, uncomplicated UTIs and women can be treated in short courses of antibiotics. You're going to do that wisely based on culture data, and you're not going to overtreat them. We know that recurrent UTIs are common in women, and that some education will go a long way for prevention. Asymptomatic bacteriuria should not be treated, and maybe we should ask if we should be screening if not necessary. Urological workup, even though they're coming to you and you feel like you should do something, the guidelines say that you don't need cysto, you don't need upper tract imaging unless you've warranted it by eliciting some complicating factors. Our number one thing to help prevent recurrent UTIs in postmenopausal women is vaginal estrogen cream. Prophylactic low-dose antibiotics are there when you're really at a loss, with minimal side effects. Sort of, even though the data said 6 to 12 months, I've used it for 2 months with good outcomes, anecdotally. And just briefly, you will all hopefully be utilizing telemedicine as a platform to treat acute UTIs. At United Urology, we do have a virtual care pathway that we believe will be utilized, whether a call comes into the PAC, whether a call comes into the office, or a portal message comes through to a patient. The idea is that we're going to try getting them onto telehealth visits to screen and treat for UTIs instead of trying to practice medicine over the phone and then chasing cultures or coordinating care with culture drop-offs in sort of a discombobulated way. So a lot of us will be on the virtual visit, and our job again is to order up your analysis and culture and sensitivity, and then the goal is that those results are going to come to whoever ordered them, even, you know, it might be a day or two after a telehealth visit day. But this is really the flow that we just wanted to share with you. It's not set in stone, but it's what we're developing, and we hope that a lot of your knowledge from tonight will help us. Telemedicine is a little tricky though. COVID and situations where somebody's hopping on a call with you because for some reason getting to the office is difficult. So when you do talk to them on these phone calls, you're going to get the history, you're going to find out what their symptoms are, you're going to find out if they had previous cultures or if they had antibiotics they took in the past and what they were, and if they have complicating factors. And you want to strongly encourage and make it easy to set up their urine analysis and urine culture, whether we're doing that in-house or getting them to LabCorp or Quest and sending over the transmittals. If you can, if they buy into it, your job is really just to drag it out for a day or two till the results come back, and encourage fluid intake, over-the-counter analgesics like the Aza, the Tylenol extra strength I talked about, or you can prescribe Pyridium or Urabel. If they get in that day and they have a positive urine analysis and you went through everything and you want to empirically treat them, go ahead. But if you could drag it out, the better. But we know sometimes, patients will strong arm you and you might be a little bit more prone to prescribe antibiotics empirically than you would in office. I think there's a little wiggle room here. Patients are afraid to come into the office because they have predisposing issues and it's COVID time and things like that. And some people have really even been resistant to dropping off cultures and things like that. So do your best to encourage and empower them. But there might be a one-off where you feel like you're betraying the guidelines and call something in. But we understand that telemedicine is a little bit different and it's your job to use your best judgment. The last thing, and I promise this is the last thing, we're just touching on this novel commercially available test for UTIs. So this is something that you might have at your disposal in the office that you may or may not be prompted to use. It's this idea that we have new urine tests that detect uropathogens much, much greater and with much better sensitivity than a standard urine culture. These include the Vicar Urine ID, the Microgen DX, which is available at Chesapeake Urology, and the Pathognostics Guidance, which is available at Tennessee. Real quick, Microgen DX, it's a two-step test. You take a urine sample. It does a first run through where there's a polymerase chain reaction to screen for 16 types of bacteria as well as yeast, and you get an upfront result within 24 hours. It does take 3 to 5 days for a later report to come out where it actually looks at those recognized bacterial strains that grew out and populated if there are resistant strains within the genome. This is helpful for a lot of people who, we talked earlier about how there's 2 different strains of an antibiotic, and on the culture, the predominant strain grew, but very easily the one that was resistant to the drug prescribed overgrew and they had persistence of UTI. So that's how these extra PCR or DNA or RNA-based tests may be helpful. Pathognostics is a little bit different. They have assays for different things, urinary tract infections, prostatitis, interstitial cystitis, etc. And they utilize PCR in the same way, but they screen 45 pathogens with 38 resistant genes. And they actually compare things to phenotypic data and pooled antimicrobial sensitivity results, which is a little bit different and is based on region. And these results are a little bit faster. There's only one report. So there's just a breakdown of the novel UTI kits. When do I use them right now? Really, it's that recurrent UTIs that are unresponsive to culture-based antibiotics over and over again. And maybe you did do a workup for complicating factors and something else is not going on. And you're just like, I gotta find out if maybe a bug that doesn't culture right on these standard plates is there. And I also use it for any young woman that I think might have suspected atypical urethritis, more the burning in the urethra or the pain in the urethra, because ureaplasma and mycoplasma are atypical bacteria that do not grow very well on urine cultures, but can be picked up on these, like on our Microgen DX. And then I know how to treat them. If they have ureaplasma or mycoplasma, I'm going to treat them with a 10-day course of azithromycin first and then maybe doxycycline second based on the antibiogram around here. And I also encourage them to have their partner treated, because if that atypical bacteria is on their partner and they have sex, they're just going to get reinfected. So I do utilize this test if I have a suspicion for young women who's maybe they're all negative urine cultures but has the burning in the urethra, and I want to rule out an atypical urethritis. So I really do thank you guys for staying on the call. I know that was probably exhausting, but just want to have tools to put in your toolkit, like I said, talk tracks and some literature and some guidelines on how to best reassure and set our patients up for success. So I'll take any questions.
Thank you very much, Laura. That was great. There were a couple of questions that came through your presentation. Did you see those, or do you want me to read them out to you?
You can read them out.
First one was, when reviewing a culture, when sensitive is noted, can you comment on the numerical quantitative value when making an antibiotic decision?
So I think the question is asking if colony, if it's 10 to the 5th, I think two asked that question, do you know?
Kara?
Yeah, so I usually wait I think, Kara, if you're asking that it's 10 to the 5th colony forming units. If it's a very reliable patient, and we said 30% of those patients, that's less than 10 to the 5th, if they evolve a few days later, and I know that they're UTI players, I might prescribe them, but I try to hold off like the guidelines say.
I think what I was trying to ask is that sometimes you'll see sensitivities and there's different values assessed. And sometimes, I mean, it's still saying sensitive, but there's different numerical numbers. Are you looking at like lower numbers? I mean, I know you sort of gave your hierarchy.
I got you now. You're talking about the MIC,
Yes.
The mean inhibitory concentration. Those are specific to the antibiotic. So you might see something like macrobid's MIC is 16 or less than 16, but this one is less than 0.4. Well, aren't you going to use the 0.4 one? No, each antibiotic is different. So as long as it's sensitive, it's fine. When it's gonna populate to intermediate or resistance on its own, but you can't compare head to head like a 16 for macrobid compared to, I think the Bacterium sometimes is, as long as it's less than 32, it's fine. Those are individualized to the antibiotic.
Thanks.
The next question was, historically, I have not seen Monurol on sensitivities per culture results. Any changes with this recently?
I have not seen it recently, so that's where, if you look at that broad spectrum, I think we covered E. coli and Enterococcus, but specifically those highly resistant strains. You will see some of these novel UTI diagnostics, which might have fosfomycin on them as checkboxes as options. And that's the only place I've seen them populating. But when I see all resistances and the patient has all allergies and it's an E. coli or multi-drug resistance, I will offer them up a fosfomycin, and then, say we need to get infectious disease on board. Because you're right, they're not part of our culture and sensitivity descriptions right now.
Thank you. Next question was, what are your thoughts on using Hiprex for suppression and prevention?
So I'm not screen sharing anymore, but I personally use it as a last resort. I don't use it often. So let me see if I could screen share real quick.
Dr. Giusto, I think I asked that before you got to the slide, so I think you already answered.
Okay. I mean, it's on there and it's on my sheet that I'll share with everybody, but I gave a one-liner here of everything that I pull out of the toolbox. I don't think people stay on it, and they're big pills, and I think we could do other things. If you could get somebody to buy into the estrogen cream and they stick with it for 2 to 3 months, they do probiotics, they're on their Theracran or their Allura because they have E. coli UTIs and they're on the D-Manos, then I think, after you stick with it 2 to 3 months, they don't need the Hiprex. So.
Thank you.
So guys, I know we had a late start. I know you guys stuck on late into the night. I really appreciate all that. you know, I'll make sure with this paperwork I send out, I'll also share my contact information if anybody wants to shoot me a text, give me a call, send me an email to talk about, you know, tough cases or you know, what next. I'm happy to help with any of that.
We had one more question. Do you have time for one last question, doctor?
I do. Everybody stayed on, so I respect that 100%.
For pyelonephritis, I know certain antibiotics are better than others for proper kidney penetrance, but was taught to treat for 2 weeks. Is this course too long based on your complicated UTI pathway?
No, so I mean, I think our UTI, once it's pyelo, it's upper tract, and you're right. That's when we lean on the Cipro. There is a list of like 2 or 3 medication in my leaders. You know, I always used to carry around that have the best penetration of the kidney tissue, and I think the minimum course is a week. So no, your teaching's correct. And pyelo, just for everybody as a side note, it's technically a clinical diagnosis. You know, flank pain, fevers, they'll often go to the ER and diagnose that. And they don't even need a CAT scan. But then the other thing is, if it's noticed on the CAT scan, there's perinephric stranding consistent with pyelo, you want to make sure they're symptomatic. And then treat them, like we said, with that 1 to 2 week course.
Thank you very much, Dr. Giusto, and thanks for everyone for coming tonight.
Yeah, thank you everyone again for your patience and time, and look forward to everybody helping out with the pelvic program.